do think masks can be extremely effective, trying to do socially distancing type things when we can, trying to do outdoor activities when we can. So all those things are I think, preferential and help prevent the spread big time. That's still probably our greatest protection from causing bigger outbreaks. And then I think it's looking at certainly, hopefully one day we'll have things like a good vaccine to help deliver to the general public and everybody that will hopefully help protect us as well. As far as other preventative things, I think that still remains to be seen. I do think treatments are starting to get a little bit better as far as how we deal with the disease and when people do get sick. And perhaps even things like masks might be decreasing the amount of spread going to people. So even when they do get exposed or sick with it, they may be not getting as sick because they're not getting as much of an exposure as they were before. So there is something to the amount of viral spread.
Welcome to the EnVibe Live podcast with Amy Parker and Cheryl Dunn. By tuning in, you are joining a community that will inspire you to increase balance, wellness, and joy in your life. We'll offer expert information and insightful conversations to help us all on our journey to live more EnVibe. For more information and articles, remember to also check out our website at envibelife.com. That's EnVibelife.com. And we're grateful that you're here. Welcome to the EnVibe Live podcast with Amy Parker and Cheryl Dunn.
We're here today with Dr. Jeff Yorio. Dr. Yorio is an oncologist with Texas Oncology in Austin, Texas. And since, I don't know, Dr. Yorio, you'll be able to tell us, but somewhere close to the beginning of COVID, you started using your sort of keen research and analytical skills to compile actual numerical data on COVID trends you were seeing in our community and post those on Facebook. And you've developed a little bit of a following by doing that. Has that surprised you?
Yeah, a little bit. I think way back in March, we didn't have a lot of data out there, about our local community. So I sort of put together some small graphs to try to reflect some of the way that we look at the national, scope and how that would look in Austin. And so I started doing that, and I guess it gained a little bit of traction amongst some of the physician groups I was in. So then it started to gain kind of this bigger traction on social media. So yeah, it was a little surprising to see it pick up like that, but it's been good to be involved with, and kind of my goal has always just been to try to talk about facts and lay them out there the best I can interpret them, and not necessarily try to influence people one way or the other, but just trying to tell the story of what's going on. And as a doctor, I've certainly had to deal with COVID-19 in our community and have become heavily involved with that to some extent throughout this whole process and throughout the pandemic. And so to me, the virus is extremely a real thing we have to be concerned about. At the same time, dealing with some of the ramifications of what has happened in society and how do we deal with that, and where do we find that balance. And so that's kind of why I've tried to keep up with that message as much as I could, and hope that coming from a doctor in the local community that could be helpful.
Yeah, I think that's fabulous. And I think that's why you grew so much popularity, is because your intention there of just giving the facts, not telling people what to do. With the facts, they can choose their own life with that. And that you're trying to just give people some balance of what's really going on. And
speaking of balance.
Yeah, you might not know it, but balance is the whole backbone of EnVibe Life. We really try and help people find balance in their daily life. So it was awesome that you brought that up right off the bat.
Yeah. In fact, I think, why don't we back up for just a second and hear a little bit about who you are, Dr. Yorio. I know you've had an interesting pathway into the practice of medicine in general. We'd love to hear about that. And then just tell us what you're doing now, what your areas are now, so our audience will know where you're coming from.
Sure. So yeah, actually, I went to the University of Texas here in Austin. I grew up in near Fort Worth, so in a town called Burleson, just south of Fort Worth, and so native Texan. And at UT, I was a creative advertising major, so that was what I graduated in, and moved off to New York to be a copywriter at an ad agency, and worked for a few years. And as I was doing that, I kind of felt it wasn't something I could see myself doing the rest of my life. And so I started to have to look at what other things I would be interested in. And I'd always had a connection with science. My dad's a scientist, and so I'd always done things with him to some extent when I was growing up. And so that kind of drew me back. And I like the idea of having that kind of personal connection with patients and being able to help people in that manner, a little bit different from what I was doing in my other career. So that's what sort of drove me to transition to go to medical school. Not a lot of people go from advertising to medical school. So I thought,
you probably had to play catch up a little bit there, did you?
That's right. I actually came back to UT for about a year because I had to do a bunch of my pre-medical requirements. Right. And then we moved to Dallas, and I was at UT Southwestern for medical school and for internal medicine residency. And then did my fellowship in Houston at MD Anderson for oncology and hematology.
Great.
Wow, that's a lot.
Yeah, it takes a lot. Yeah. Little did I know when I made the switch, it'd take about 10 to 11 years for me to go through all that process of school and training. So.
Yeah, well, it had to have been a true calling for you to make that commitment.
That's right. Yeah. So no, I've always been happy with making that change, and couldn't imagine myself doing anything else now.
Awesome. That's great. So talk about what's going on with COVID in Austin right now. Amy and I have 2 kids that are in the classroom. They went back, I guess it's been 3 or 4 weeks now. Mm-hmm. And Amy has...
Well, I have 2 in college, one in Colorado, one at UT, and then one in high school.
But the high school are still Zooming.
Yesterday was the first day in person.
Got it. Okay. Mm-hmm.
So it's something we've been following from that perspective, just as mommies in the community, really, and what's going on. But I know that you've been really, I think, combining your medical expertise, your analytical nature, research background with your ability, I'm sure, through advertising to present information in a way that people can understand and interpret. So, yeah, tell us a little bit about what the current state of affairs is in Austin, Texas. And it's October 14th today. This will publish, a few days delayed, but in the middle of October, where does Austin, Texas stand?
Sure. So, of course, we had a pretty, at the beginning of this pandemic in the spring, Austin and most of Texas did okay. And of course, we were really shut down during those times. And then, we really experienced this big wave of COVID-19 in the summer, June through August. And that was really our peak times. And of course, we saw our hospitals kind of fill up with patients a lot at that time with COVID-19. And fortunately, what we've seen over the last few months is things have really kind of settled back down to more of a plateau, I'd say, a manageable plateau with cases. And, on average, we're seeing less than about 100 cases per day. And the amount of people in the hospitals here in Austin have been less than 100, with COVID-19, really for the last month or so.
Total. You mean total hospitalization?
Total hospitalization. Yeah, total people in the hospital at any given time with COVID-19. So sort of thinking somebody occupying a hospital bed, because right. That was always one of our big worries. If we have 1,000 beds in the Austin area, and 800 of them are occupied by COVID-19 patients, that's a troublesome problem to have.
It was scary at the beginning. Yeah.
Correct. And so it's definitely been more manageable in that respect. And numbers had come down quite a bit. Maybe over the last week or so, we're seeing a slight trend upwards in hospitalizations and things like that. Still nothing near what nothing too bad quite yet. So it'll be interesting to see what happens in the next few months. But
so this summer, did we hit close to 800 COVID patients in our 1,000 beds?
And I use those kind of as rough numbers. We have more than 1,000 beds in the Austin area.
Okay, I wasn't sure.
I just kind of threw out some numbers there. I actually don't, off the top of my head, I don't know how many true hospital beds we have in Austin.
Okay.
But we had a high percentage of folks, and so yeah, at its peak, we had over almost 500 people with COVID-19 occupying hospital beds in Austin. Not quite 500, but almost. We got to that level in the Austin area, and so that was a pretty major amount, because you had what happens then is our normal hospitalizations, our occupancy rates are probably in the 70 to 85% ranges, and so when you have a whole new disease that's taking up 30 to 40% of the hospital, then all those things that we normally would use a hospital for get pushed out, and so that's always been one of the big worries with COVID-19, is how it could overwhelm the hospital system. And I think that's what we saw early on in the pandemic in Italy or in New York and those type of places, where it just overwhelmed these hospital systems, because things happen so quickly and so fast. And kind of some of the ramifications we're seeing of those type of issues are what happens to the people that are having heart attacks and strokes and those type of things, because those diagnoses started to go down because they weren't getting admitted to the hospital or were too scared to come to the hospital. So I do think there's been some ramifications with that. And we've seen, I know some of our cardiology colleagues have talked about how the number of admissions for heart attacks went down pretty dramatically during the spring and somewhat in the summer. And that's worrisome, because typically those diseases don't just disappear. They're still happening. They're just not showing up and getting the care they necessarily need. And as an oncologist, we've seen some of that, certainly, where we know that screening during the sort of spring and summer went drastically down. Something like the amount of screening going on for breast cancer or colon cancer went down dramatically. And actually there was some publications which showed that the incidence of kind of the 6 major types of cancers went down by almost 50% during the spring in the United States, which is crazy, because that doesn't mean there wasn't the cancers are still happening. It's just they're not getting diagnosed. And so we've certainly seen that in our practice, where our kind of new diagnoses of cancer we weren't seeing the same levels we normally see, which just means they're going undiagnosed. So that was also a worrisome thing that happened with everything with the pandemic. And so I think we have to try to figure out how do we balance all that out, look back to balance, and how do we live with this virus, and try to figure out how to make things like hospitals work and clinics work, and still get people necessary medical care for both COVID-19 and for all the other diseases we normally deal with.
Do you think it's a little better? Do you think people are feeling more confident in being able to come in and keep up their routine screenings now?
I do. I think what we've learned is safe ways to help run clinics and different medical facilities to try to limit exposures, for people, try to make it a safer environment for people to come in and be able to receive that care. And I think people are definitely starting to feel more and more comfortable with that, and either coming to the hospital or coming into clinics to do those type of things. And of course, we've helped with using things like telemedicine. So we were very early adapters of telemedicine in our practice, and I know a lot of people around town were as well. And that's helped us just kind of offset the number of actual people that come into clinic on a daily basis by using some of these visits that we can with telemedicine. We can do those so they're not actually having to come physically to clinic. And then the people that have to come physically here, they're still able to, and it's a little safer because the number of people here are not quite as much. So I do feel like most of the medical practices in community have done a really great job of offering protection to both staff and to patients, around town. So I feel like people can, feel like they're going to be safe coming in to do those things.
Well, I want to spend a little more time, let's shout that out to everyone. We just, Cheryl and I just interviewed a friend of ours a couple of days ago who's a breast cancer survivor. It's Breast Cancer Awareness Month. And in telling her story, part of her story was she had just 1 year, she didn't have her mammogram. and it was that year. And, we've been in this for 7 or 8 months now. So that really, I think, alarmed all of us when we sort of had that check or realization. So I know it's made me kind of go back down my list of what have I put aside and what have I kept up with appropriately. Because you kind of think a few months, it's just a few months, but a few months can be a big deal.
That's true. It's, it's one of those things. It's not a big deal until it is a big deal. And so that's why I think it's important to really try to keep up with these things, because they are definitely ways to catch a diagnosis early, or, with colonoscopies to potentially prevent even cancers from occurring. And certainly with breast cancer, mammograms will help catch things early, or catch precancerous type lesions that maybe we can prevent something else from happening. So I think it's certainly important to still keep up with those screenings. And unfortunately, it's one of those things that got pushed off a lot during this year because of everything else going on. So, and we're starting to see some of those ramifications in practice, where people are probably getting diagnosed a little later than they normally would with certain types of cancer.
Mm-hmm. Yeah, that's a tough one. So what I find interesting is UT started back in the classroom late August, I would say. I might not be accurate on that date, but UT's been back, some virtual, some classroom, depending on what students are signed up for. And I know that they let 25% in to go see the football games after they got a negative COVID test. So we haven't seen from my knowledge, it doesn't seem like there's been a huge amount of cases at the university, which we did kind of expect that might happen. So what do you think's going on? And you might know better that there are a lot of cases, and I don't know.
Mm-hmm. Yeah. And I think it's always tough to track some of these things. I know probably those first month of UT being back, I think UT kind of had a little bit of a surge of cases that they saw. But certainly not to the big extent that maybe a lot of people thought were going to happen. And so it's tricky, so maybe they're not happening. Maybe people don't always get tested because they're young, and they get a little bit sick and they don't feel too bad, so they don't go in to get tested. And, overall, being college age, most of them are pretty healthy and probably do okay with COVID-19 as far as a sickness, as far as getting sick and don't get too ill. And so that's one of those things, how many people are actually getting tested or not. That's hard to always say. I think the hopeful thing would be that maybe they're not interacting as much with some of the other community as large, and maybe that helps to some extent. And hopefully a lot of safety measures that have happened, like wearing mask places in classrooms or places they go, help prevent that spread. I think the things that we've probably seen on college campuses where spread has been happening has been more in stuff that's been kind of off-campus type activities, where you're, whether it's parties or whether it's gatherings and things like that they're not doing things like masking and socially distancing and those things. Whereas, at the football game, they're mostly having to wear masks and they're having to be outside, where it's probably a little safer, and the crowds are definitely much thinner than normal. So perhaps that's safer. So maybe that's why in something like the football game, we're not seeing that as much. They're also, for students at least, screening those people with tests before they come to the actual game. So that's probably preventing a lot of potential positive cases from exposing other people at somewhere like a football stadium. So I think that's probably why we've seen some of that. It's still it's still summer or fall. Well, now fall, but feels like summer in Texas. So so you can still do a lot of things outside. So I think that's still very helpful with mitigating spread with this virus, because if you can eat outside and even attend a gathering outside, probably that spread is going to be much less likely than if we're all cramped inside a small conference room or a small auditorium, things like that.
And so there are a lot of different statistics that are thrown out, and you yourself present the different metrics. What do you think is the best thing to watch? I mean, there are the infection rates, the hospitalization rates, the death rates. If we're just, someone out there is just kind of trying to gauge how their community is doing, what's the best thing to follow?
I kind of think the hospitalization rates are probably the best thing to follow to give you a sense of what's going on with the disease as a whole, because it's telling you who's getting, it's telling you the population's getting exposed or getting sick enough to get in the hospital. It's probably the most real number we can get to. It's harder to fabricate hospital data on who's actually getting admitted. Yes, there's going to be an occasional patient who got admitted for something else and then was found to have COVID-19. But for the most part, most of those patients are getting admitted because of that COVID-19 diagnosis. And so to me, that's kind of the best trend to follow, because as we've seen with all the testing pros and cons, there's not everybody gets tests all the time, or, maybe even with things like positivity rate, where you're actually looking at, the number of positive cases per test. Well, if UT decides to screen 20,000 people all of a sudden, that's screening 20,000 asymptomatic people. And so that the positivity rate might be actually very low. If we go screen, everybody that walks into the emergency room, that's going to be probably a higher positivity rate because they're sick and walking into the emergency room. And so that's just a matter of, where those tests are happening and things like that. Still an important number, but I don't think it's I think doesn't always tell the perfect story of what's going on, because it's based on how many tests are getting done out there or not, who's going to get those tests, that type of stuff. But hospital rates, I think, are really hard to fabricate one way or the other. And so if you look at those trends, I think that starts to tell the story. And what I've seen, one thing I've tried to track is just number of positive cases and hospitalization rates, occupancy with COVID-19. And the two track very closely together. So, when the case numbers go up, the hospitalization rates start to go up. When the case numbers go down, the hospitalization numbers do start to go down. So it tells you, while they may say, oh, there's only 100 cases today, that may or may not be accurate. Maybe there's 200 cases that day, but the trend is probably the most important thing to follow. Is it trending upwards? Is it trending downwards? And that seems to track pretty closely with hospitalization rates. Death rates, of course, I think are important to follow, but that's always going to be delayed, because somebody who dies of COVID-19 is probably three to 4 weeks often after their original diagnosis. So you're going to get late indicators with those death rates. And also, a lot of talk has been about death rates have probably gone down some over time with COVID-19. And a lot of that is because we've done a much better job in Austin and Texas and the United States of protecting places like nursing homes, our older population that definitely has that much higher risk of dying from COVID-19. So I do think
that really is a substantial number of the deaths nationwide at this point occurred in nursing homes.
Correct. Yeah. If you look at just Texas as a whole, they've started to publish some of this data, and probably about a third of the deaths were probably ultimately related to nursing homes or long-term facilities. Now there's still other deaths that happen out there, of course. But that is a big portion of it. And I think that's what we saw a lot in places like New York and Italy when we had the really high death rates early on.
So is there a trend in the person that is being admitted to the hospital? Is it an age trend, a race trend? I even heard the blood type thing,
Yeah, certainly. I think, for sure, older age, people who are older who get it are much higher risk of having to get hospitalized. If you're over 80 and you get COVID-19, your risk of having to be hospitalized is extremely high. And you start to see that go down through the decades, right? And of course, if you're 18 and you get COVID-19, extremely rare you're going to get hospitalized for COVID-19. But then the other risk factors, obesity seems to be an extremely big risk factor, and particularly people who are morbidly obese. I think their risk of hospitalization is going to be much higher, and they have a much tougher time when they do get hospitalized, as far as getting over this illness. And then with that, probably diabetes has been a big risk factor with it. And then some of these other things being immunosuppressed, patients with cancer are also at risk. So those are some of those big risk factors. So it's, I can certainly say there are people in their 40s, 50s, 60s who were seeing hospitalized, and a lot of them do have some of these comorbidities. And the reality is a lot of Americans have a lot of these comorbidities out there as well. So so there's, many people are still susceptible to some of those risks.
So that brings the next question: what can we do? I mean, is there anything you're seeing out there? You hear vitamin D or, other things to boost your immunities. Have you seen any evidence of any of that being beneficial or advisable?
I don't think we have any good hard evidence that those kind of things are effective or work. So to me, the best things we can do is decrease spread and prevent spread of the virus itself. And so those are, trying to have, I do think masks are extremely effective. I know it's been a hot debate for a long time for people. And of course, early on, people have to realize, early on in this pandemic, we didn't have masks in a lot of places in the healthcare community. And we didn't know for sure that masks would be extremely effective in preventing spread of this virus either. And so there was a big push to try to really get masks and PPE to medical facilities. I can tell you in our own clinic, we don't use masks usually on a normal basis, right? And so we use it for a few procedures that we do on a normal basis. We do it for some of our, infusion nurses when they administer chemotherapy, they'll wear masks. But so that's in normal times is what I mean. Now, of course, everybody's wearing masks all the time, but initially we didn't have that kind of supply to be able to give even to our own employees, let alone to say the whole world needs to wear masks. And so that was a big problem early on. And then now what you've seen is I think that can be extremely effective. And you look at places like Asia where they've been able to mitigate spread a lot better than perhaps we did in the United States. And that's because they had that a lot more readily available, and it was kind of in their culture a little bit more from some of their previous pandemics that they had, or in virus outbreaks that they had. So they were used to doing those things. And so I do think masks can be extremely effective, trying to do socially distancing type things when we can, trying to do outdoor activities when we can. So all those things are I think, preferential and help prevent the spread big time. That's still probably our greatest protection from causing bigger outbreaks. And then I think it's looking at certainly, hopefully one day we'll have things like a good vaccine to help deliver to the general public and everybody that will hopefully help protect us as well. As far as other preventative things, I think that still remains to be seen. I do think treatments are starting to get a little bit better as far as how we deal with the disease and when people do get sick. And perhaps even things like masks might be decreasing the amount of spread going to people. So even when they do get exposed or sick with it, they may be not getting as sick because they're not getting as much of an exposure as they were before. So there is something to the amount of viral spread that goes on.
So I have a question, and you might not have this answer, but you're probably the best person in the room to have the answer. So say I start today running fever. I go get my test. In 2 days, I get my positive. I have heard that, so say today is a Wednesday, I got my fever. I should contact everyone I've been in contact for the 48 hours prior to my fever to let them know that they could have possibly been exposed. Is that 48 hours a good window of safety measures, or is it bigger or is it smaller? What do you know about that?
Yeah, and so I will say, the CDC sort of recommendations are exactly what you said. So basically the thought is that you certainly can still spread the virus while you're asymptomatic, and the thought is that that's probably highest in those 2 days prior to you actually getting symptoms of some sort. It's probably not 100% perfect, but I think it's a pretty decent measure to look at and say. That's probably when you were at the highest risk of exposure. If you were wanted to be really conservative and especially if you're around maybe some higher risk individuals, maybe you take it back a few days even before that. But that is the CDC recommendation is tell everybody that you were in contact with the previous 2 days, to when you got those symptoms, to let them know, and this way they're advised that they could have been exposed to the virus actually.
Okay, another question. When you say when you got those symptoms, is the symptoms when the fever starts, or the symptoms could have been the sore throat, the allergy feeling? Like, it's
correct. And so probably I'd say more of, the sore throat, the allergy feeling, I first started to notice something wasn't quite right, because a fever may not be the first, manifestation of that disease, right? So it could be that, I had a sore throat for a day before, and then I got a fever. And so really you got to think about when those symptoms, any symptoms really first started. And you can tell that a little bit more in hindsight. Oh yeah, really I started to feel kind of bad on Monday, and then Tuesday I got the fever, and that's when I got worried.
It's hard. The cedar trees are blooming in Austin. Everyone's going to be walking around paranoid right now.
It is tough, and I think that makes it really tricky with allergies. And it's been tough in our, as doctors, it's been tough because somebody calls, oh, I've got this sore throat and runny nose or whatever it's going on. Oh, okay, it might be allergies. But now, do I have to think about COVID-19, and do we bring them in here? That kind of stuff. So those are big questions we have to think about constantly.
And I thought you were going somewhere different with that question. So I'll throw one at you that you may or may not have the full answer to. All right. So that day you feel the symptoms. Is it still recommended that you call someone before you go in, or are there places go in and get tested? At what point should you get tested, and how should you go about doing that?
So I think if you've got symptoms that you're concerned about, and of course that'd be, shortness of breath, cough, fever, GI symptoms like diarrhea, body aches, those type of things, then I think that's something to be concerned about. There are certainly places around town that you can either drive up to, go to get testing, or that you can make appointments to get testing. Also, not a bad idea to call your primary care doctor and call their office and discuss with them, and if they have recommendations as well, if you've got those symptoms. And I think that would probably always be preferential, because then at least you've got a medical professional you're working with to figure out the diagnosis and what game plan. And then just in case it's not COVID-19, what are other things that could be going on as well? So I think that's preferable.
And then how long of a delay is there normally between when you might feel symptoms and when you start therapeutics? Because I think, we all just saw the president, right, had symptoms and within a few days was feeling better because, man, they were on top of that.
Yeah.
Immediately. He's got a whole staff surrounding him tending to that. What about most people?
What are they giving people like us?
Yeah, and that's tough, So I'll say where most of our data right now with COVID-19 is really in people sick enough to get admitted to the hospital, honestly.
Right.
And so the things that have found to probably be the most effective so far are dexamethasone, steroids. We know the president got steroids. And so dexamethasone, there was a trial that was done in the United Kingdom where it showed an actual mortality benefit for people if they got steroids. And those were really for people who were already sick enough to require oxygen. So for people who did not require oxygen, actually the steroids did not seem to be helpful, and maybe actually slightly detrimental. So it would be so it's better if, or where we have the proof is that somebody's sick enough to be in the hospital and sick enough that their oxygen requirement is such that they need supplemental oxygen. And that's where the steroids are most effective. Convalescent plasma, which is something I was really involved with during this pandemic. Just as a hematologist, we deal with these blood products a lot. And so personally, I was seeing a patient, helping a patient in the hospital, and we found out a way to be able to get convalescent plasma, which is essentially collecting plasma from somebody who's already been sick with COVID-19 and has recovered, and we collect their plasma because it presumably has those antibodies to fight off the infection, and then we give that plasma to the sick patient in the hospital. And so I was very involved and helped us get this program started in Austin. to be able to work with our blood bank to collect convalescent plasma and then get that to patients with COVID-19 in the hospitals. And and we treated, probably over 500 plus people with convalescent plasma in the Austin area as a result. And we worked with a big trial through the Mayo Clinic that was run nationwide. And in that trial, they treated something like 60 or 70,000 people nationwide, with convalescent plasma. And so ultimately that led to an FDA approval of convalescent plasma as a treatment for COVID-19. There's still some, discussions about pros and cons and things like that, but it is at this point an approved therapy to give. And so if people are sick enough, again, requiring oxygen, if they were in the hospital, then convalescent plasma would be another treatment that we would potentially offer people at that point. And then there's a medicine called remdesivir, which is an antiviral medicine that's also approved. And then, of course, there's all these other potential therapeutics that have have some excitement around them, but don't actually have true approval. And so those are things that we're still trying to learn more about. The president received basically a monoclonal antibody. So kind of think of it the way I talked about the convalescent plasma, but think about just being able to identify the super duper antibodies that can fight COVID-19 and making that into a medicine, which is kind of what he kind of received. And so that looks promising. It still doesn't have it's still very, still what I would consider experimental and is not something that's approved and not something that's available everywhere unless it was under some type of clinical trial right now. But looks, maybe potentially promising, but we'd have to learn more about it. And then the one other therapeutic we think about still is probably blood thinner. We know COVID-19, when people are sick, they have a much higher rate of getting blood clots, things like pulmonary embolism and DVTs and other things. And those have been a big deal. So being on prophylactic blood thinner can be helpful as well during hospitalizations. For people in the, not in the hospital, that's the big question. The honest truth is we don't have any great yet medical approved things that look like they are extremely effective yet. And some of that's tricky because the vast majority of people who get diagnosed it's a virus. They'll recover, they'll get over it eventually and not have to get into the hospital and not get those things. And so it can be hard to prove, something that's really effective if you take 100 people and 90 of them are going to recover okay, and 10 of them are going to end up in the hospital, it's going to be really hard to prove, if I give those 100 people this medicine that we've made a difference. And so that's what's tricky on the outpatient setting and why most of the therapeutics have been really aimed at how do you treat the sickest of the sick folks first and figure out how that works.
But there's a lot of promise, the bottom line.
Yeah, I think what happened is and that's the amazing thing about the, medical community, pharmaceutical community is that, everything started to point towards this target and everybody went to work on trying to figure out how do we attack this disease and what can we learn about it and what are new treatments we could offer for it. And if there's treatments we have that may have been effective before, or we use for other things, maybe they could be used for this. And so people started to work real hard to find these answers. So I think that's where a lot of that promise comes from. And then just the supportive care, I think, improved as well. Like anything, if you, we've been treating, lung cancer for years and years and years, right? And so we have lots of data and we have lots of information about different things that can happen. So we have a lot of knowledge about something like that. COVID-19, we had no knowledge about, 8 months ago or 10 months ago, and now we have more, but we're still all learning. We're building the plane while we fly it. So
I'm going to go back a little bit to our schools because I feel like that's hugely important.
It's on everybody's mind.
It's on everybody's mind. We talked about colleges and what you thought was going on there, but let's talk about the high schools, the middle schools, and the elementary schools, because as parents, we're like, what do we do? And I do get from my middle school that my 6th grader is in, since they've started back in person, they've only had 2 cases, which I think is great because it's a big school, I feel like. And then my 9th grader who's in high school, I don't have the numbers in front of me, but I feel like personally, I get an email from the school 2 to 3 times a week that there's a new case. I don't know if that is a whole lot based on the number of students there, because I haven't personally done the research. But what do you feel is going on in our community amongst the different districts that are right here in Austin?
Yeah. It's so yeah, tough question to answer and figure out, and it's a little hard. I'm trying to figure out how we can track that better or learn more about it. And of course, not all every district's doing things a little bit differently. Every schools within districts are doing things a little differently on what in-person school looks like. How much are they really doing? How little are they doing? And so that can be a little hard to always put a good summary on what's happening. I think what we're, as a parent myself, I think I worry about kids not being in school for a long time. Of course, they're missing out on vital education and the vital socialization they get.
And the mental health of that is a big deal.
Big problem. And that's where, to me, I've always tried to say, how do we balance these things? How do we walk this rope between COVID-19 is real and it's a bad disease, and I think we all need to accept that. And then we have to figure out, how do we live with it, and how do we figure out how to deal with it? Because it's not going to disappear in the next week or two. It's going to be around, certainly for a long time. Perhaps we'll have better ways to prevent it spread and treat it as time goes on. But it's a problem that we have to figure out, how do we, work into society and what's important to us and things. And so I've been one of those advocates of saying, yeah, I think we need to figure out, how do we get kids back to school and do it in a safe manner? And I don't know that we have great data yet, but nationwide, you're seeing a little bit of, first off, they thought schools are going to be these big super spreading locations where all of a sudden you'll have 500 cases in 2 weeks at schools, and it'll start to spread to the community. And they haven't really seen that quite as much, and I think some of that's due to a lot of the measures that schools put into place, right? Mask, distancing, trying to figure out smart ways to do classes, and maybe decrease the number of kids that are in classes, and those type of things. And so I do think those measures are being very successful. And if we can do those types of things, then maybe we can prevent schools from being a place of spread. And no, it's not going to be perfect. That it still stinks that my 11-year-old has to go to school with a mask on and can't do quite the normal stuff, but it's better than what she was doing otherwise, right? And so I think we have to accept it's not going to be totally normal, but can we do it at least to some extent where we get kids some of what they need? And so hopefully that can be something we can continue to work on and do it in a smart way. And to me, I think where you're probably seeing a lot of the spread is more in the activities and places, not so much on campus, but on off-campus activities. Like I said, in colleges, probably a lot of the spread's been at parties or other places where those kind of protective measures aren't able to happen as much. But perhaps at schools, we can really try to limit the types of spread that go on, or at least that's what seems to be trending that direction. I don't know, we'll have to get more and more data as time goes on, but
I do feel like the schools are being safe. I mean,
I think they're working really hard.
Yeah.
I think they're working tremendously hard, and I think they're doing a great job when kids do go back at trying to really prevent kids from and teachers from being exposed. And we've got a little, evidence just from, like, in the medical community, we've got hospitals and clinics, right, that have been open for some time. And, I'll see 20 patients today, right? And I see 20 patients every day. And most of those are going to be in-person interactions. And most of my what we've noticed is our staff and other patients are we're not seeing spread within clinic walls, right? So we're able to hopefully do this in a safe manner. I cannot prevent that the next patient that walks in the door got exposed 3 days ago and is actually asymptomatic with COVID-19. I have no idea. But what we can do is try to lower the chance that if they are here, they could spread that to other people. And that seems to have been successful so far, where we're not seeing these big spreading events happen in places like that. And hopefully it's things, practice like that can translate to schools as well. And that seems to be the case if they can do it, right.
Well, and you started this by saying it's all about balance. I think even balancing the fear with feeling
Completely.
like we can handle the situation.
Yeah. And to me, that's it. How do we take this situation and how do we, that's where I say it's like, we must accept that this is real, because denying it is not a smart thing. Because I think that's just us feeling like it's not a big deal. And I do think COVID-19 is real and it's a bad disease. But we can't stay in a shell forever and ever, and we can't hide away from life forever and ever, because that has also huge ramifications. Whether that's, people staying at home to have their heart attack and not coming to the hospital, or it's, the 10-year-old who needs to be in school and doesn't get that education and that for a whole year, and what's going to happen the rest of their life because they didn't get that, what they needed this year, and how behind are they going to be, or what are those ramifications? And so how do we try to balance things out? I think that's what we, as humans, we have to adapt and figure out how to make it work.
Yeah, for sure. So speaking of balance.
Yeah. So what we like to ask all of our guests at the end or towards the end of the podcast is, what do you do personally on a daily basis?
Or regular basis.
Doesn't have to be daily. We found that sometimes that's harder to get in. What do you do to get balance in your life?
Oh, good question. So yeah, as a doctor, balance is probably not one of our better traits sometimes, but because we all work a lot. So I like to run, so I try to run at least a few times a week. Usually I can do that. I'm not so good every day, but at least 3 or 4 times a week. Try to get that in for some balance. Try to always devote some family time, for sure. Try to really carve out weekends to devote more of that family time if I can. And then other things I do, I like to play the guitar, so I balance myself out by doing that, even if it's for 5 minutes in a day or something, just to get that kind of, or where I don't have to think about other things, or some sort of mind escape. Yeah. So,
yeah. Well, and we always say, like, I'm a huge proponent of meditation. And when people say they don't have time, I'm a fan of the 3-minute meditation, or you mentioned the 5 minutes of guitar. So we say, you know what, 3 or 5 minutes is a whole lot more than 0.
Yeah.
And I'm I have a hard time sitting, as we discussed. So I'm an avid meditation runner, right? I like to run and be very mindful, because once I get done with that, I feel it's cleared my mind completely, because I really focused on whatever my intention was to focus on during that run.
Yeah, no, that's great. And I agree. I think running is always one of those where you can sort of escape and try to, put everything out, put all the outside noise out of the way for at least, 30 minutes or whatever it is.
Yeah, whatever we can get in, right?
Whatever we can get in, yeah.
Well, thank you so much for joining us today. I think this has been very helpful and informative to our community. And
I think we've put a lot of information out there today. Hopefully people will find it useful and helpful.
Yes. So thank you very much.
Yeah.
And thank you everybody for watching or listening to the EnVibe Live podcast today, and our conversation that we got to have with Dr. Jeff Yorio. So
thank you very much. Thank you for having me.
Of course.
All right. You guys have a good one.
You too.
Bye.
Thank you for listening to the EnVibe Life podcast. For more information and to join our community, be sure and check out our website at www.envibelife.com. We look forward to sharing with you.